Okay, so today I'm going to talk to you about shoulder eval. So first thing you want to do is a history. So I want to ask questions like what happened, the mechanism of injury, what type of pain are they feeling? Is it radiating pain? Is it stinging? Is there numbness? Where does it hurt the most? On a scale of 1 to 10, 10 being the highest. What activities hurt the most? What doesn't hurt? Does everything hurt? What have you done since the injury? As in, like, have you taken any medicine? Have you seen any physicians? And what sport does the athlete play? And how old the athlete? After you get a good history, you're gonna want to observe the patient, his shoulder. You want to palpate the clavicle, the acromion, the coracoid, the scapula, all angles, up in the trapezius, the deltoid, bicep tendon, bicep, tricep, infraspinatus, supraspinatus, rhomboids, pec minor, pec major. You're going to want to basically palpate just about everything in this general area. After you get observation, you're looking for swelling, you're looking for any ecchymosis, effusion, gross deformities like you would see in AC sprain or any sort of fracture or dislocation. So after you get an observation and you do your palpating, when you're palpating, you want to ask, like, does it hurt the most here? Does it hurt back here? But after you get the palpating done, you're going to want to move to range of motion. So I like to start off with external rotation and internal rotation. Also shoulder flexion, shoulder extension, shoulder abduction, adduction. I like to test external and internal rotation at different with also abduction of the shoulder, so like this and like this. Also, you can have them reach over to their opposing scapular shoulders, see how far they can get. You want to compare all ranges of motion with bilaterally. I have them grab this shoulder. This is the I want to say the Applebee's stretch test, and then the other one is come in behind like this and tell them to touch their opposite scapula. So you want to compare those bilaterally. You want to do passive to see just how far you can really crank them into position without pain, and then you want to do active to see how full range of motion they can give on their own. And if they seem to be handling active range of motion, tolerating pain pretty well, then you want to move to manual muscle testing. And all the motions I just went through, you're going to do that. So for external rotate, I like doing them at the same time. I don't want to step in front of the athlete so block the camera, but you're going to have them bend elbows at 90, keep elbows close to their side. I want you to push out both hands as hard as you can. You want to do that. Make sure they're pressed as hard as they can. Make sure you're giving a good force. Internally rotate. Same thing with, you can relax. Same thing with shoulder extension, flexion. You're just going to put a resistance. And you want to see if there's any pain. Right where there's pain, that's usually positive. So once when you do your manual muscle testing, your palpation, your observation, your range of motion, and your history, you're going to have a pretty good idea of what's going on. But then there you have your special tests. So I'm going to go over a couple special tests. I'm going to start off with the sulcus test. The sulcus test, the examiner, you're going to want to grab the top part of the shoulder, and you're going to grab the wrist of the patient, and you're going to pull down on the arm, and you're looking for the glenohumeral head to drop a little bit, and there's going to be a little indent, and that's testing for inferior instability in the glenohumeral joint, and also laxivity in those superior glenohumeral ligaments. Also, while you're doing that, you can also look for, see if the glenohumeral joint and the scapula depress, which is another test. It's the AC traction test, and that's just a positive sign for an AC sprain. So sulcus test, you're only looking for the head of the glenohumeral to come down, which means that there's actually pathology within the joint capsule, and then with the glenohumeral joint and the scapula depressing, that's usually a pathology in the AC. Now, since we're talking about an AC, you can do the AC compression. So you're going to want to put one hand on the anterior portion of the shoulder, one hand on the posterior portion of the shoulder, and you're going to press, and you're looking for any pain or any shift in the clavicle or acromion if one depresses or elevates. If an athlete has an AC sprain, they're not going to like it, and it's going to hurt a lot. So that's another test for the AC. Another great test is the apprehension test, which, since I don't have someone filming and my phone's just chilling right there, I'm going to do it with him sitting, but I like doing it laying down because it just is easier and I feel like it works better. The apprehension test is testing for any like slap tear or any anterior instability, anterior superior instability in the joint capsule, or possible labral tears. So this, you're going to want to have your arm on the shoulder like this, and you're going to want to pull the scapula up in place, and with elbow flex at 90 and abduction, you're going to want to crank this, externally rotate the humerus, and a positive sign would be a patient being apprehensive about it, pulling their shoulder forward, or lots of pain, maybe a clicking feel or pop. This is, like I said, implications of possible slap tear or anterior instability in the joint capsule. Then you can do the relocation, which it will be hard for me to do sitting, but if they were laying down, you would have them supine. You would press the anterior portion of the shoulder down onto the table, so you're holding that glenohumeral in the joint capsule, and you're going to repeat this same test, the apprehension test, but the positive finding would be that they either increased in range of motion or took less pain, which implicates the same thing as the apprehension test. Another slap tear test is the O'Brien's test. You're going to want them to extend their arm and internally rotate their humerus, and you're going to tell them to flex the shoulder and so lift up like this, and you're going to apply resistance, and they're going to lift as hard as they can. You're going to apply a strong force, and if they have extreme weakness and pain, it is a positive sign for a slap tear lesion. If you externally rotate the arm and have them press and pull up, if this does not hurt as much as when the arm was internally rotated, that rules out kind of a slap tear. But if this hurts more, then it could be an AC pathology as well. The Jurgensen's test for the long head of the bicep tendon, for like tendonitis or the transverse glenohumeral ligament tear. This is a test for that. You're going to want to start off like this, their hand internally rotate, and then they're going to press out like this. They're going to externally rotate, like relax. They're going to externally rotate while supinating their hand, and they're going to come out like this. So it's going to be one motion. You're going to apply a resistance. So go. And you're going to want to have your other hand either stabilizing the elbow, which I like to do, and looking right here where that long bicep tendon comes and attaches, looking for any popping or movement or pain that the patient may say. And or you can actually palpate that tendon and feel if you feel any popping or tendon. That's a transverse glenohumeral tear or possible just bicep tendon pathology. I'll do one more test, the empty can test. You want to have your patient go like this, and you're going to apply a force down. And this is checking for your supraspinatus rotator cuff muscle. If there's any possible tears or instability or laxity, they're going to be they're going to show weakness and pain if that's the case. And actually, one more rotator cuff muscle test I'll do is Hawkins test, which is also testing rotator cuff pathologies. You're going to want to abduct the shoulder, and then you're going to want to internally rotate the humerus. And if there is any pain, popping, clicking, it's usually a rotator cuff pathology, tear, tendonitis. Also, it's usually the supraspinatus that is affected. So there's the general overview of the shoulder eval. Hope you enjoyed it, Thomas.